Hello, everyone. Welcome to another SonoWebinar by Aprende Canada. My name is Leonardo Faundes. I'm the owner and founder of Aprende Canada, where we offer sonography continuing education. Today's topic is a second look at grossly normal pelvic scans, debunking the myth of endometriosis. It is my pleasure to introduce you to Irina Sochirca. And double pleasure because, and very proud that she was one of my students when I used to work full-time at the Missionary Institute. So it's great to see how much she has progressed in the profession. So Irina graduated from University of Toronto in 2009 with a bachelor's degree in cellular and molecular biology specialty with high distinction. She later graduated from the ultrasound program at the Missionary Institute for Applied Health Sciences in 2012 and worked in Toronto and the UK as both a locum and permanent member of staff in the public and private sectors. She has also been a mentor for sonography students and junior sonographers. Irina is a recipient of 2 honorary contracts with consultant gynecologists from other leading hospitals in the UK with the aim of learning detection of deep infiltrating endometriosis on ultrasound. So without further ado, again, it's my pleasure to introduce you to Irina.
So welcome everyone. It's a real pleasure to be here. Okay, so when it comes to endometriosis, I think endometriosis is a bit of a unicorn condition. It's like everybody has heard of it, but when it comes to ultrasound, we don't quite see it. So I think hopefully with this presentation, people will start their endometriosis journey, and I'm secretly looking forward to getting emails from everyone to say, Irina, I have finally figured it out, and I have finally identified my very first endometriosis case, deep infiltrating endometriosis case. So when it doesn't quite matter whether you have, whether you are just a newly qualified sonographer or whether you have 30 years of experience. It's not something that we learn at uni, and that makes it quite interesting and thrilling, and at the same time quite tricky as well, because there's plenty of journals out there. The machines are excellent. So this endometriosis specialists have been identifying deep infiltrating endometriosis on ultrasound for probably at least 10 years. There's plenty of material out there. So I think in general practice is a little bit of a situation of severely underreported endometriosis, and unfortunately it takes about 7 years on average for a woman to be diagnosed with deep infiltrating endometriosis from the first symptoms of presentation. So imagine women go from person to person, from specialist to specialist, trying to figure out why they have all this chronic pain, and some women have a really hard time conceiving. Basically they're just giving them some paracetamol or ibuprofen, and hopefully the pain will go away, but this pain keeps coming back, and they just the quality of life suffers quite a bit. So hopefully everybody will start kind of expanding their field of view a little bit when it comes to a pelvic scan, because it's not that you need an extra skill. The transvaginal probe stays the same, the machine stays the same. You don't need, that's the beauty of it, you don't need anything extra, and you just want to see a little bit more and just understand where to look for it. Because the good news about endometriosis, as devastating as it is for a woman that does have it, that the good news for us is that endometriosis follows quite a predictive pattern, which makes it good for us, helpful for us, because we now know exactly where to look for it. And just to add a little bit of a, so I think when it comes to endometriosis, like I said, there's plenty of material out there. There's plenty of really phenomenal lectures, presentations, and conferences, and plenty of journals and articles how to do it. But I think from my experience, what I have heard from other sonographers is that there is so much material that it almost feels intimidating when this is what you learn. We learn on ultrasound how to assess the uterus, the lining, the ovaries, adnexa, cervix, but then, and this is sort of like our baseline, what we learn, and we think we're good, and we are good at identifying fibroids, describing cysts, describing polyps, and so forth, you know, but it's very intimidating to jump straight away into like this complex pathology that they present in the articles with all this complicating terminology. So my aim with this presentation is to sort of simplify it a little bit, because I think sonographers don't quite know, don't quite have that starting point where to begin to even look for it. So today I'm going to show you quite a bit of normal for you to practice after this presentation. And I promise you that if you do this sort of simple techniques every single day for every single transvaginal scan that you do for about a month, I can guarantee it's 100%. It's my promise to you that within a month you will identify your first deep infiltrating endometriosis case, and it's probably going to be an endometriotic nodule on the bowel, most likely, because I feel like those are the easiest ones to see. Yeah, so I think you know, so when it comes to I think that's it, you know, it's a bit of a stepping stone that we do need help with. So imagine like if you're trying to lose weight and you go to the doctor and the doctor says, well, just try to lose some weight, just try to eat healthy. And then you're just saying, well, doctor, can you please give me a little bit of a menu? What do I have to eat for breakfast? What do I have to eat for lunch and dinner? Just write it down for me and how much I need to do it. So it's a little bit like that with this kind of scanning. You kind of want a little bit of a system where to start from and what to do and when. So without more talk, let's just jump straight into it. I'm not going to be doing a lot of theory in terms of where endometriosis comes from. There's so much literature about that, and we only have roughly 50 minutes to cover the material. So I want to show you as many little videos and photos as I can, so that you take the most out of it. And please write your comments and questions, and please don't hesitate to stop me. Okay, so let's jump straight into it, into the presentation. Right, so this is our agenda for today. Like I said, I'm going to briefly go over the background information. Then taking patient history is an absolute key with endometriosis, because they have such versatile and yet common symptoms that you're going to see in a moment, and you're going to realize that women, those are the symptoms that you see over and over and over again. And in fact, if you do, for example, a whole day of just purely gynae scans, I can guarantee one of them is going to be endometriosis for sure. Right, so but the bulk of our presentation, we're going to focus on the ultrasound examination with dedicated views, and rest assured, I will give you some homework so that you will hopefully enjoy. So let's start with the background information. Right, so like I said, it's a bit of a unicorn that we have all heard of, but we just don't quite see it too well. So it's a chronic condition where endometrial cells, endometrial-like cells, that migrate and infiltrate in the adjacent pelvic structures outside of the uterus. It affects about 1 in 10 women of reproductive age. So like I said, just by stats alone, if you do a full list of gynae, one of them will be endometriosis for sure. And like I mentioned previously, it takes on every 7 years to get diagnosed from initial presentation with symptoms. It's a fairly poorly understood condition, but we do know it's complex. We do know there's several factors that contribute to it, and we do sort of have several hypotheses how endometriosis is being spread, but there's no so chances are it's a bit of a mix of several several ways how it disseminates, it is linked genetically as well, especially if you have a first degree relative with endometriosis. It does manifest itself as a chronic pain, and it can contribute to reduced fertility or infertility. So when it comes to patient history, so I'm just going to be checking my time as well, just to make sure that I don't over talk, because I tend to over talk. This is my absolute favorite topic, right? So taking patient history. So it is important to know. So do not hesitate to ask patient a little bit more while they're there, why they're there for the examination. Don't just go by the GP referral to say, heavy periods, you know, or IBD, intramenstrual bleeding, you know, something like that. Do ask them a little bit more, especially when you see they have had scans before, and then the patient will be eager to tell you as well, I've been to this, I've been to that, nobody can ever identify anything. So a lot of times, patient with endometriosis, they come with this kind of like a series of normal scans, but they keep having those pains. It's sort of like very, very similar. You'll see there's a pattern to it, and you probably have noticed that from your practice as well, depending on your experience. So again, so what is the reason why they're there? Do they already suspect endometriosis? Has she been previously diagnosed? If she has been diagnosed with endometriosis, it's important to find out how exactly she has been diagnosed, because chances are, also we live in a quite of multicultural place, so people come from all over the place, and you know, for example, you can have a woman from somewhere in the, you know, from France telling you, I've had a scan back in France and I've been told that I have endometriosis by a scan. So, you know, so that is probably a lot less credible than, for example, a woman that I'm not trying to say that quality of scanning is better or worse in a country or another. That's not at all. But what I'm saying is just a scan itself is probably a little bit less reliable than, for example, she had a laparoscopy or she had a previous MRI as well. Something, especially if she had a laparoscopy, that is more reliable. And especially if she's already undergone a previous surgery, that she has for sure been diagnosed, for example, stage 1, stage 4, stage 3 endometriosis. Does she have period pain? Does she have just chronic pain that is not related to period? Does she have any pain during sexual intercourse? Any pain while urinating, or sort of UTI-like symptoms? Some women can even see some blood in urine as well. So that's not necessarily, blood in urine doesn't necessarily mean that they have just kidney stones or some sinister renal pathology. Do they have pain while opening bowels? Again, it doesn't necessarily mean that they have some bowel cancer or some sort of inflammatory bowel disease like Crohn's or ulcerative colitis. Do they have any back pain, or do they have difficulty conceiving? And also, quite important, how do they have children, and what is the mode of delivery? Have they delivered by C-section? I will show you one slide in the end about C-section delivery. An abdominal wall lesion, because interestingly enough, with the history of C-section, you could see this abdominal wall lesions that actually looked quite sinister, but they really are just endometriotic deposits within the abdominal wall. And I'll show you how it looks. It kind of has a bit of a classic appearance to it, especially with this history, so that at least you know that it's a bit of a less alarming, because the lesion looks a bit spiculated. It looks like hypoechoic and sometimes quite vascular as well, and it gives them quite a bit of pain. Okay, well, let's go into some, oh, sorry, I have, okay, key question and answers. We have a question here. Could it be endometriosis if there is pain only during menstruation? I have some pain between periods, point more towards endometriosis. As far as I'm gauging into the question, can this be pain only during periods? Yes, it can, only during periods, because it's actually, if you think about it, it's endometrial cells that that are implanting somewhere else, right? So when women undergo menstruation, they bleed, so they shed this endometrial cells. So it's those endometrial cells that are responsive to the hormones during your period. So yes, it could be pain only during your period. Yes, it could be. And they're so versatile from woman to woman. Believe it or not, some women experience no pain whatsoever. So the threshold of pain can also be quite variable. So imagine it could be an absolutely, endometriosis could be an incidental finding, you know, and they just they had no idea that they had it, especially if they're on birth control pills. And birth control pills, most of the time is the management, the pain management as well. When a woman is diagnosed with endometriosis, they're being put on birth control pills to control the pain a bit better, especially those back-to-back pills when they don't menstruate. So yes, it's a bit of a versatile presentation. It's a bit variable from woman to woman. Thank you for the question. So hopefully I've answered that. Okay, so when we're going to talk about, oops, I'm not sure, I think, right. So when we're going to talk about scanning for deep infiltrating endometriosis, that's sort of, I tried to split this in 4 different stages. So the first stage is our routine scan of the survey of the uterus, endometrium, ovaries, cervix, and the adnexing. And then, so that's something that everybody does. So I'm not even going to focus on that because I trust everybody does it and everybody does it well. The next part that we're going to focus on is a bit on ovarian mobility. So hopefully as well, that's something that most people do as well, because a lot of time the radiologist that you work with is going to ask you to do that as well. It depends where you work too, and then we're going to focus on anterior compartment, and then we're going to finish off with posterior compartment. So that's probably the last 2 parts is something for you, something hopefully new for you, something that you could take some strong learning points from this presentation. Okay, so when it comes to ovarian mobility, let's jump straight into some videos. So I'm going to start off with absolutely normal mobility that hopefully you are already doing. And if you're not doing that, I strongly encourage you to do, because that's such an important assessment during the scan. So I'm just going to play this video. So, and it's important for you to sort of build that library in your practice, in your mind, your personal kind of recognition pattern, if you will, that once you're going to see 100 norms, eventually, and if you're going to practice it regularly, eventually the abnorm is going to ring strong alarm bells in your head, and then you're just going to know for sure, okay, I know what normal is like, then I know for sure this is not exactly normal. So I'm going to play this video. So as you can see, this ovary is absolutely mobile, and when it's normal, so the woman can experience a little bit of discomfort here. So you can see how mobile is the ovary is not stuck to the uterus. It moves freely from the pelvic wall. It moves freely from the bowel. So that's an absolutely normal ovary. I have sort of a similar video, but with the right ovary as well, just to see just another normal ovary. So you can see this one as well. So absolutely normal. So everything moves freely. The bowel, from bowel, pelvic wall, and uterus. Okay. So now when you can already see here on the next video, so there's a couple of potentially small endometriomas. That's the first time that she's come for the scan. So, I mean, I think those are endometriomas. I guess differential diagnosis would always be a little bit, especially with a small size like that, with a little bit of hemorrhagic cyst. But have a look at this mobility. So you see when we do the same sliding signs, you see how, yes, it sort of moves freely from the bowel and the pelvic wall. However, it is stuck to the uterus and it moves together with the uterus. So when it comes to endometrioma, which is sort of the same process as endometriosis, but it's localized to the ovary. Having said that, so when you see an endometrioma, for sure, it could be just an isolated finding. But if you see an endometrioma, chances are the risk of having deep infiltrating endometriosis in other places is increased. especially if you see that ovary is non-mobile. So do pay attention when you have an endometrioma, that do check for mobility as well. And it is important to note. So I know that you're not reporting in Canada, but do potentially, well, I'm just suggesting, I guess, do write for the radiologist who's going to look and report after your images non-mobile or partially mobile, right? So you can label, for example, here non-mobile, mobile, 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 something like that, to let the radiologist know that it is partially mobile and where exactly is mobile, where is non-mobile. But you can have a conversation as well with the radiologist that reports after you, and then you can ask them how exactly you want them to know, to let them know when you assess for mobility. Okay, so now that is the case with an endometrioma. That's exactly what I just told you in terms of isolated findings. So imagine this is a 4-centimeter endometrioma, but let's have a look at the mobility of this ovary. So even if there's a 4-centimeter endometrioma, do you see how mobile everything is? So actually this ovary is not stuck to anything, and in fact, like, she didn't have any other suspicious places of deep infiltrating endometriosis. Okay, so now that we're done with ovarian mobility, and like I said, potentially there's nothing new about it. Potentially you've already been hopefully doing that in your everyday practice. So we're going to switch on to continue with the assessment of the anterior compartment. So when we have a look at the anterior compartment, we have a look at the bladder as well, at the bladder lumen. If there's any endometriotic lesions inside the lumen, and most likely you're going to see within the bladder base or bladder dome. Now, but they're not a very common finding. So I don't actually have any pictures or videos of that, but you can see plenty online. I don't have any videos of the assessment of the bladder because I'm pretty sure everybody has done that a certain stage of assessment of the bladder lumen with a transvaginal probe, especially when you probably get post-void volume with the transvaginal probe sometimes. Right, so, but anterior compartment comprises the bladder, the sort of the space between the bladder and the uterus, of the anterior serosa of the uterus. So that's called the anterior cul-de-sac or intravesical pouch. And also it's important to check the ureters as well. So we're just gonna, it's actually a fairly straightforward process. I'm gonna show you a video as well. So hopefully you're going to find it. It's a bit tricky once you, maybe for the first couple of times, but it's actually one of the easiest things to look for, the distal ureter. So you're going to see it's quite straightforward. So let's have a look at the anterior compartment. So I'm going to focus on the intravesical pouch first. So again, there's a space here between the anterior uterine serosa and the bladder, and we're going to check for the positive sliding sign in between. So I guess it's also important to say that when it comes to anteverted or retroverted uterus, it's important where you put the probe. So that's something that you do automatically. I don't think it's something that we do necessarily consciously, but let's take a step forward and actually do it consciously, and we're just going to pay attention why. It's going to become important in a moment. So for the anteverted uterus, we usually insert the probe into the anterior fornix. So you can see that's where the probe is, anterior fornix. So when you assess the mobility of the intravesical pouch, you sort of do at the same time, you push with the transvaginal probe, and then you push on top of the woman's stomach. So please ask for permission as well, if that's all right to touch. They're for sure going to say yes, well, hopefully they're going to say yes because it's important for them. That's what they're there for. But I think it's important to ask for permission before you touch the patient. Right, so let's have a look at the video. So you can see here, so I press from top and I press with the transvaginal probe at the same time. You can see this positive sliding sign of the anterior cul-de-sac. So it's quite straightforward. And again, you're going to do this. Hopefully you're going to do this for every single patient. Hopefully you're already doing this for every single patient. And when it's normal, it's normal. You don't have any doubt that it's normal. Therefore, when it's abnormal, you're going to know it's abnormal. Okay, so when it comes to a retroverted uterus, you can see here the probe is like the tip of the probe is actually in the posterior fornix. And you do exactly the same, you just pay attention to this area over here. So we're still assessing the space here between the anterior uterine serosa, the bladder, and the bowel here. So I'm still doing the same thing, pressing with the probe and pressing on top of the patient's tummy. And you can see the positive sliding sign. You can see how freely it moves. Okay, so let's have a look at the ureters. So for the ureters, you sort of, to visualize the distal ureters, you sort of pull the probe slightly out, and you're going to see the bladder a little bit better. So it's important that's also important for the assessment of the bladder to have a little bit of urine in the bladder as well. So not overly full, but a little bit of urine is important just to assess the lumen, to make sure the bladder is free, is clear. So when you sort of, in order to see the distal ureters, you sort of start midline, and you're going to see the urethra straight away. So it's going to be sort of a hypoechoic channel there. So that's your starting point, and then you sweep to the side. So let's see the sweep for the right distal ureter first. So you see me sweeping to the right, and that is over here, your absolutely normal distal ureter. And if you pay attention, if you pay close attention, I'm going to play this senior loop in a second, you actually going to see the sort of the movement inside the ureter as well. So that's just your normal filling up of the bladder. Yeah, so you see that just over here. So, and that's kind of the norm. Again, you're building up your personal library of the norm. And we're going to see the same thing with the left. So I'm just sweeping. So again, I'm coming back to midline, and then I'm sweeping to the left, and then you're going to see that normal left ureter. Yeah, so that's how small they are, the thin they are, but they're unmistakable on the scan. And again, when they're abnormal, you're going to see they're abnormal. So let's have a look. And that's one of the cases. Actually, it was the same lady, if you remember, that I showed you that isolated endometrioma, the 4-centimeter endometrioma on that patient. That was an isolated finding. However, when I checked the ureter, have a look at the ureter. So do you already see how thickened the ureter is? And if I just stay on it and watch it, so do you see how it was dilated and then it's sort of compressed. So it's sort of transiently dilating. So potentially there's a bit of a stricture there, and most likely it's because of the presence of the endometrioma as well, just probably purely by size. So when it comes to constriction of the ureter, it could be intrinsic or extrinsic, meaning, so in this case it's probably extrinsic, meaning that it's the pressure is coming from outside of the ureter, so creating that bit of a pressure. So you can see, and hopefully that's going to prompt you into extended the study to check the kidneys as well. So this lady had mild left hydronephrosis, but it's important to sort of follow and complete the assessment. So yeah, sometimes they present with back pain as well. Okay, so now that we have seen quite a few norm of the anterior compartment, let's have a look at the posterior compartment. We're still doing well with time. So this is probably one of the most common places for endometriosis. Let me just check if there's no other questions. Okay, so hopefully everybody's following me well. I really hope so. Hopefully nobody fell asleep. So posterior compartment, and that's probably, it's not just one of the most common places, but it's probably one of the easier places as well to detect endometriosis, deep infiltrating endometriosis, especially nodules on the bowel. They're quite obvious, and they're quite unique in appearance as well. Okay, so when it comes to the posterior compartment, so what we have a look at, so again, we're checking the pouch of Douglas, but we don't just check the pouch of Douglas like you see here. We just check usually like fluid in the POD, but pouch of Douglas, actually, we assess for mobility or that positive sliding sign all the way from the fundus to the posterior vaginal fornix. Okay, so all the way from the fundus, and you'll see. So again, with the same token, like we were assessing the anterior compartment, the anterior cul-de-sac, that's exactly how we assess the posterior cul-de-sac. So if it's an anteverted uterus, our probe is still in the anterior fornix, and you press again. You do exactly the same technique, but you actually have a look. You have a look how freely the uterus moves. So same technique. So you can see just how mobile this uterus is. So you will know for sure if a woman is, yes, it is a bit uncomfortable, but you will know the difference between discomfort because you're applying a bit of a more pressure because the bowel is moving, and pain. Women with endometriosis that have severe pain most of the time during the scan. And that's also one of your clues as well when you assess for, when you do a bit of a longer survey, that where exactly is the pain is, where the patient is most sensitive. So let's have a look at the retroverted uterus. So it's exactly the same technique. So your probe is in the posterior fornix, and you just press together with the, you can see how freely it moves. So it's just an absolutely normal scan, absolutely normal mobility of the uterus. Okay. Now, this is, hopefully, again, this is something that you've been doing from before. Now this part, the next part, we're going to be looking at more or less the bowel assessment too. And in order for us to proceed to assess the bowel, we need to insert the probe into the posterior fornix. And it's a bit of a conscious move. So most of the time we see anteverted uterus just by stats alone. We see most of the time anteverted uterus. So you sort of pull the probe out and then insert it into the posterior fornix, and then you're going to see the bowel. So let's have a look just at this process alone. So I took this little video. So you see I'm taking the probe out and kind of angle slightly more inferiorly, and then insert into the posterior fornix. And you can see that posterior wall of the vagina, sometimes endometriosis is found here as well. So let's have a look here again. So I'm taking the probe slightly out and then tilt inferiorly, and then insert into the posterior fornix. So this is our starting point in order to see the bowel. And you already see here, so we're going to be assessing the anterior wall of the rectosigmoid. So I think that's the next video here. So rectosigmoid, and it's not like you do it step by step like in a robotic way. You kind of do one assessment, and it kind of happens everything at the same time. So you're assessing the anterior wall, posterior wall, but maybe at the beginning it's just going to take you a little bit longer just to kind of have that system in your mind, and then it's just going to flow freely, and you're going to do it quite quickly as well. So let's have a look. So that's a bit of a quicker move. I'm inserting into the posterior fornix and have a look at the bowel. So, so this woman, I mean, you don't need to have a prepared bowel. You don't need to have a prepared bowel because endometriosis, most of the time, not most of the time, it implants and it affects the anterior wall of the rectosigmoid colon. So you actually, the bowel lesions you're going to see here on the anterior wall, you're going to see it's a very distinct thickening of the bowel wall, and most of the time something is going to be non-mobile. Most of the time bowel is going to be stuck to posterior uterine serosa or like a uterosacral ligament. Let me have a look here. So this is probably, yes, so this is not a video, this is just a still image. So that's what an endometriotic lesion on the bowel looks like. It has a quite distinct, actually there's two of them here. It's quite a distinct appearance to it. So it's most likely not, it's very unlikely for this to be a bowel lesion. And you can imagine there's reduced mobility for this lady. So imagine even if she complains, she presents with bowel symptoms and she undergoes colonoscopies, it's very unlikely for them to see when they do a colonoscopy because it affects the anterior wall. So it affects the anterior muscularis. So this lady potentially is going to go from specialist to specialist and undergo many procedures to try to identify where her bowel symptoms are coming from. And this is a rectosigmoid column. So this is actually the left ovary. The bowel was stuck to the left ovary here. Okay, so let me just see, any more questions? Nope. Okay, fine. So hopefully we're doing well. Right, let me just, that's just another, I just wanted to show several images of the pathology. This was quite an advanced, actually, case of endometriosis. You can see she's got an endometrioma. There's a deposit on the anterior wall. Also, again, when describing, and you'll see that in the literature, I will leave you, like I said, like I promised, I will leave you with homework. So that's going to be, it's going to go in a little bit more detail how exactly to describe it. But just like with anything that you see on ultrasound, you measure with 3 you measure in 3 planes, and what's important for the bowel lesion description is to hopefully describe just how much it affects, and hopefully you'll be able to describe the layer of the bowel, what layer of the bowel it affects. And there's a great lecture that I'm going to leave the name of the lecture for you to watch, because then he goes in much more detail in terms of layers of the bowel. So hopefully you'll be able to describe the layers of the bowel and just how far from the anal verge that lesion is. So you would measure from just about this point, and then you kind of slowly measure section to section all the way to the anal verge as you take the probe out. So this is probably about 10 centimeters away from the anal verge. And why it is important, it plays importance when the patient potentially undergoes surgery. So there's a much better outcome if the bowel lesion is more than 5 centimeters away from the bowel, from the anal verge. So there's less chance of fistulation. Okay, so now this is probably the absolute trickiest part when it comes to endometriosis, because those are such common places to find endometriotic lesion, and is here on the uterosacral ligament, or shortly put USL. So uterosacral ligament. What's important for you to understand and to note is the location, because this uterosacral ligament is kind of similar in terms of detecting on ultrasound. You're not going to see a normal uterosacral ligament because it's not really visible unless there's fluid in the pelvis. So, but the important to know the location. So it's just about the internal os, at the level of the internal os of the cervix, and those uterosacral ligaments meet at the torus at the back of the uterus, so in the posterior aspect of the uterus, and that's exactly where we're looking for them on ultrasound. Like I said, it's a bit of a tricky part, especially when they're tiny, but I'll tell you what, women can have an absolutely normal scan with the tiniest lesion on uterosacral ligament, with the tiniest deposit on uterosacral ligament, and they're in agony. So I think I have a bit of a, okay, this isn't a normal scan. This is a normal uterosacral ligament, and I could only delineate it only because there was a little bit of fluid. So just have a look, pay attention here. You're going to see I'm just sort of delineating it millimeter by millimeter, and you just sort of see. So if there's no fluid, yeah, you can see it's coming in nicely into this into the view. So if normally without fluid, I mean, you're not really going to see it. So but it's not a septation, you know, it's just a normal ligament, right? So okay, so let me show a little video. So hopefully I'm not going to lose you here, because it's very tiny, and I didn't really find any videos where they're quite massive, but sometimes they are massive. So have a look. Again, your strategy, just think when you're sort of sweeping around the cervix, posterior aspect of the cervix at the level of the internal os. So you're just kind of paying attention to this area over here. So have a look. Does anything sort of looks outside the norm? Does anything at all looks abnormal to you? So have a look. Does anything at all sort of catches your eye? So I'm kind of going over it over and over again. So I don't want to delineate it on purpose, just in case you're going to catch, you can test yourself. So I'm going to play it again so you can test yourself. Does anything at all catches your eye? So again, I'm going right now over and over it, so you actually can see it now in the screen. Okay, so I'm going to play it now again, and I'm going to delineate it for you. So it's right here. Yeah, so it's out and now coming back into the screen right there. So there's a tiny lesion, and that's the uterosacral ligament. Is this thickening? Sorry, we have a question. Is this thickening? The normal scan, no. When there was a little bit of fluid, but that was definitely the video that I just showed you. That's definitely thickening there. There's an endometriotic nodule, and you can see they kind of all look similar, hypoechoic, irregular in shape. That's kind of their pattern. Okay. So this is a bit of a more complex case. And actually what she had, and that kind of puts a little bit food for thought for you when you assess the location of the ovary as well, because now have a look. So this is the uterus, this is the right ovary, and you're going to see the left ovary. Why is the left ovary in the POD pulled all the way to the right? Why is that? So hopefully you're going to see the abnormal uterosacral ligament, the thickened uterosacral ligament. So right over here, that is the abnormal thickened uterosacral ligament. And you can see actually here, both the right and the left ovary are stuck to the right uterosacral ligament. So the right ovary is being pulled over. So the left ovary is being pulled over to the right, and both of them adhere to the uterosacral ligament. I forgot to mention sort of an important terminology when it comes to positive sliding sign and negative sliding sign. So when something is stuck, so like when you describe pouch of Douglas, when you say when you see sort of a negative sliding sign, so everything is stuck together, the term for it is obliteration. So you would say pouch of Douglas is obliterated. So yeah, so this you can see sort of just remember that I haven't noticed that I haven't mentioned that. So you can see the uterosacral ligament. Have a look again. So that's the uterosacral ligament over here, and both the right and the left ovaries are stuck to it. Okay, moving on. And that's again the uterosacral ligament over here. So that's again thickened. You're going to see it coming in. So you definitely see it doesn't belong to the cervix. It doesn't belong to the uterus. It's right there, just next to it, right there. So that's a thickened right uterosacral ligament. It doesn't involve the bowel. It's just kind of isolated thickening of the USL. Okay, so that's just a still image, but that was quite a severe case actually, and the lady was in agony. But you can see that's a bit of a transverse view, but those are both. So imagine, so like I said, the uterosacral ligament, they join posteriorly at the level of the internal os and the torus. So there we go. So both uterosacral ligaments, and in fact you can actually see the anterior muscularis is quite thickened there, and everything was stuck together. So pouch of Douglas was obliterated for sure. You can see those are kind of as I find this picture quite beautiful in terms of showing the pathology. Okay, so right, last but not least, in terms of posterior compartment, we're still doing well with time, so I'm going to speed up a little bit, is when you take the probe out, do it a little bit more with a bit more awareness now that you know that potentially the endometriotic lesion could affect the rectovaginal septum. And rectovaginal septum speaks, the name speaks for itself. So it's a septum between the rectum and the posterior wall of the vagina. And on ultrasound, it just looks like a hyperechoic space. So you're just going to see that's a normal rectovaginal septum, and you see that every single time. Now it's important for you to kind of do it a little bit slower, because you wouldn't believe how much pathology you can pick up as you move the probe slowly as you would insert the probe slowly and watch the screen, watch that space between posterior wall of the vagina and the rectum. So you can see there's that hypoechoic space in between the two. So you remove the probe slowly. You can see that's the urethra I was telling you about, the sort of hypoechoic space. And in fact, this is exactly the same view. When you insert the probe, you see exactly the same, that urethra, vagina, anal canal, and you know you're in the right place. Again, that works the other way around when you're just about to insert the probe. Okay, now this is, again, this is just an incidental finding on the posterior wall of the vagina, and it's really well defined. So it's a bit too well defined for endometriosis, for an endometriotic lesion, a bit too well defined, looks like a fibroid. However, it's a very, very, very unusual place for a fibroid to be on the arising of the posterior vaginal wall. So actually it was suspected that this woman has some sort of a lesion, and it was quite vascular as well. But in fact, she had MRI subsequently, and it turned out to be a fibroid. But like I said, it's an extremely rare place to see a fibroid. But once you do things kind of like a little bit slower and more aware, then you're going to pick up sort of subtle things like that. Okay. And right, so this is, we're all done with the with me showing you anterior posterior compartments, ovarian mobility. This is just like a little, I'm a bit gutted that I don't have my own images. I just forgot to download them from PACS, because I always have access to PACS at work, and I just forgot to download those images. But these lesions in the abdominal wall, they're related. You see them with women with previous history of C-section delivery, and you can see how they look, and they could look quite malignant as well. You can see spiculated margins, hypoechoic, and they actually can be quite vascular as well. So on ultrasound, actually looks quite concerning. But given the history, most likely it's a young woman as well. So given history, that you kind of lean towards, now that you know, you kind of lean more towards an endometriotic deposit within the anterior wall. Okay. Right, and I've seen quite recently, and it was about 6 centimeters long. Okay, and the patient again was actually quite in severe pain, and they were suspecting hernia or anything really. Okay, so just a few take-home messages from this presentation. Hopefully it was helpful for you. Please leave some comments. So endometriosis follows a really predictive pattern, so you know exactly where to look, and that's the positive aspect of it when it comes to ultrasound and detection of endometriosis. Endometrioma can be an isolated finding. However, there is an increased risk of multi-sited endometriotic deposit by about 2-3-fold. So do check for mobility, and do check for anterior posterior compartment, like hopefully like quite straightforward from the videos that I've showed you. Taking patient history is absolute key. What I forgot to mention at the beginning, so one red flag for endometriosis is actually an anteverted and retroflex uterus, especially in the presence of adenomyosis, and especially if adenomyosis affects the posterior uterine wall. So that is quite a red flag. So most of the time you're going to see with anteverted and retroflexion, you're going to see obliteration of the POD. So that's a bit of a red flag straight away. Another red flag, endometrioma that's a non-mobile ovary, or pay attention to patient tenderness. They're going to tell you, ow, ow, that is really painful for me. Some patients are going to ask you to stop the examination because they wouldn't be able to continue. Like we just saw, previous history of C-section delivery and anterior wall lesions, they kind of go hand in hand together with quite distinct appearance. Obviously, homework for you. So this is an absolute Bible when it comes to endometriosis. If there is an article to read, or to start with, I should say, so because hopefully you're going to read many, many articles about detection of endometriosis on ultrasound, is this. So please take a photo of it. So systematic approach, and it's free, it's accessible for everyone. So hopefully everyone's going to read it. It goes in detail. like I mentioned at the beginning, my presentation was more of a bridging step between, so I kind of tried to show you a lot of the norm in order for you to kind of build up your library of the abnorm. Okay, and a further lecture to watch, Sono World. This lecture from 2018 is very informative, it's very thorough, and also they're going to explain a lot more about bowel layers, and for you to describe bowel lesion as well. So please, please, please read it. It's only 17 minutes long. It's really, really good. Okay, so let's go into questions. We're just about done with the presentation. Could you send the link to the article? I don't have the link right now, but I think, should I, let me just go back to the slide. So hopefully you can just take a video, and if you Google it, I'm fairly certain you're gonna find it, no problem. Okay, so we're all done. Thank you guys so much for listening, and hopefully it was easy to follow. So please leave any comments, and I'm happy to answer any questions.
Thank you so much, Irina. It was, for me, it was mind-blowing, because there were things that I had no clue about, and I wish I knew when I was doing a lot more transvaginal ultrasound. Now I don't. I do a lot of vascular, but it would have been really interesting to know and look for those at those areas.
Sorry, I'm not sure if.
Hello?
I think my connection is going quite poorly. Hello?
Yes, can you hear me?
Yes, I can hear you well. Yes.
Okay. No, I just said that I found it an excellent presentation, and I wish I knew all this information when I used to do more transvaginal ultrasound in my early sonography days, because of the different areas that to look for. We used to look at the posterior, at the POD, but not specifically at those areas like the ligaments and things like that. But again, it's amazing how much we can see with ultrasound when you really put your mind to it.
It's amazing how much we can see, and that's the mind-blowing part about it. I'm really, really excited how much we can see, and the machines are getting so much better these days that you wouldn't believe the quality, how much the quality have changed compared to what we used 10 years ago. It's such a huge change. So yes. Hopefully it's actually not that difficult. We have another question here. Yes. How long would a comprehensive scan for endometriosis? Well, it depends how much you find, of course, because if you're going to do, so at the beginning, obviously it's going to take you a little bit longer if you're going to take that systematic approach. And what I used to do at the beginning, I had a little bit of a cheat sheet to make sure that I don't forget to look, and ideally at the end you look at kidneys as well, just to make sure that there's no hydronephrosis. I kind of go by patient symptoms. So ideally you'd look for, if they come for specifically rule out endometriosis, you kind of look at kidneys as well every single time. Having said that, if they come for just a gynae scan, and if they don't present with any symptoms of UTI, like if I don't see anything abnormal with the ureters, if they come for gynae scan, I keep it gynae scan. Yes, so all in all, if you see like stage 4 endometriosis with involvement of both ovaries, normal bowel lesions, this and that, and you're trying to measure the distance of the bowel lesion to the anal verge, and you're trying to see those uterosacral ligaments, yeah, it can take 20 minutes of scanning alone. And because in UK we have to report as well, my report sometimes is 1 page long, so yes, sometimes it could be quite, sometimes I tend to run behind. Okay, in what direction do you apply pressure with the probe when assessing anterior cul-de-sac? Okay, in what direction do you apply the pressure? That's another question with the probe when you're assessing the anterior compartment, so anterior cul-de-sac, assuming anteverted uterus. So you just press with the probe, sort of just you try it yourself, but you just kind of there's only one direction in the way.
The direction of the probe, I guess, right?
Yeah, you kind of, there's only one direction really, but you kind of try to press a little bit more anteriorly when assessing the anterior compartment, you know, and then you press from the patient's stomach. Like I said, do ask for permission before you touch the patient. or you can ask them, especially when they come and the GP already is inquiring, oh, is that any evidence of endometriosis? So you can tell the patient, okay, once I'm going to assess everything, at the end, we're going to do a little bit extra views. And if that's all right, I'm going to be pressing on your tummy a little bit. They will for sure say yes, because all of them want to get to the bottom of their, to find out where their pain is coming from. I can guarantee that. Yeah, thank you so much for listening. And hopefully it was informative, and hopefully it was helpful, and hopefully it's going to help you in your career.
I think the biggest strength of your presentation was the fact that you went into a lot of techniques, and as sonographers, that's what we do, right? It's important to hear about other techniques or different techniques, because that's our bread and butter when we scan, right?
Bye.
Bye-bye, everyone.